I'd like to introduce Jamie Bosel. She is a physical therapist who focuses on orthopedic, sports medicine rehab, and education on injury recovery and prevention. She earned her physical therapy degree from Creighton University, who managed to win their first round game, which was excellent.
Go Jays.
And she is the physical therapy lead for the Spine Center of Excellence and is a Rigo Method certified clinician for scoliosis. So without further ado, Ms. Bosel.
All right, thank you. Okay. Thank you, everybody, for coming to our conference this weekend. I hope that it's been informative for everyone and that you've picked up some new information and enjoyed your time here with us at UCSF. I am Jamie Bosel. I am a Rigo trained therapist, and I'm going to talk a little bit about something I think that's been around for a long time but is new to us at UCSF. It's called the Schroth method, and for a Schroth method therapist, we all know that we call it physiotherapy scoliosis specific exercises. So let's hop in. I feel weird standing behind the podium, so I might come out, but let me know if you guys can't hear me. First, let's just talk a little bit about the Schroth method, its origins, and how it made its way to the United States. It started in 1921 by a woman named Katerina Schroth, and she created the concept of rotational angular breathing. And it's really a mainstay of the Schroth method. The breathing techniques really make the method what it is. And she was the one who spent a lot of time researching and creating this method. A little later, in the 1980s or so, a few spin-offs emerged. Essentially, Schroth became copyrighted by the Schroth family. And so 3 schools are now available in the United States. The Barcelona Scoliosis Physical Therapy School, created by Dr. Rigo. That's the method that I'm trained in. Schroth Best Practice, created by Dr. Weiss. And then the International Schroth 3-Dimensional Scoliosis Therapy by Dr. Askelpois. Ooh, I'm not good at saying that. So going in a little bit more into Rigo method specifically, the principles are an evolution that Dr. Rigo kind of tweaked based on his clinical experience. The 4 general principles that we follow are, number 1, 3-dimensional postural correction. And before I dive too deep, really the goal of the Schroth method in layman's terms is to teach a kiddo or an adult who has scoliosis how to self-correct inside or out of a brace. And that's really my goal as a physical therapist, is to teach a kid, A, how to correct, but B, also to be happy in their own skin. Because when these kiddos and adults have scoliosis, a lot of times there's a lot of associated maybe shame, or they're not happy with their bodies. And so on a really personal level for these kids, my goal is to teach them how to self-correct and stand with pride in their spine and their bodies. And it goes back to these basic principles that were created by Dr. Rigo. So the first one is 3-dimensional postural correction. And we'll talk about how we align the blocks or the pelvis, lumbar, thoracic spine, and trunk with minimal tension, usually in a gravity limited position. Then we go into an expansion technique, which is just breathing drills, advanced breathing drills to work on torso reshaping in that stable corrected posture. We add muscle activation, which is tension, expansion, and pressure in that corrected position to create a mind-body connection. And then at the end, we always integrate that posture into either sitting or standing position, because nobody ever does things in their life laying down, especially kids who play sports. So you want to integrate that posture and that knowledge into an actual functional position. The specific principles are axial or self-elongation, asymmetrical sagittal straightening, and then a frontal plane correction, which you integrate usually in muscle activation. Can I take this with me? I'm not very good at standing behind something. I feel like I'm far away. Okay, so I will just dive briefly into the curriculum because there's three, thank you. There's 3 levels, including a basic intro level that you take online. Level 1 goes really into the basic principles and the positions and the correction strategies. Level 2 is more advanced treatment, and you're supervised and graded. You also get to work with adults. And then the level 3 is the full training of adults, post-surgery, spinal fusions, and you also get more training in learning about the Rigo-Cheneau brace. There's a lot of education required. The base course is 32 hours online. Level 1 is 48, and you can kind of see going forward. So that kind of leads me to talk a little bit more about the difference here in a few minutes between just a classically trained physical therapist and then someone who has the scoliosis education. The Rigo method specifically, you can see there's different classification types based on the curve that you would see in a radiograph. And one of the big things with the Rigo method is the stacking the blocks. As you can see, each of these blocks has a rotational component to it based on whether they have a primary thoracic, primary lumbar, or sometimes people are pretty well stacked up. So the goal is to work on identifying what classification they are and then applying that in a gravity eliminated position initially and then moving to standing. A little bit more detail of the Rigo method. Dr. Rigo, he did a ton of research, and if you're interested in any of his papers, I can make them available to you. There's a lot of research at the end, but this is just a really deep dive of the different types of scoliosis classifications and the 4 different groups that you would see, not including just sagittal plane scoliosis. So one thing I think is important to address is the difference between a classically trained physical therapist and someone who understands PSSE or the Schroth method. The Scoliosis Research Society in 2005 came out with some parameters for physical therapists to teach and treat scoliosis specifically. It's a little long, so I'll pick out the most important parts for you guys. But it's important to understand, especially in the multidisciplinary setting, that physical therapists who are trained to treat scoliosis know that it's not an alternative to bracing or surgery. In fact, our goal is to work in conjunction with the doctors and the orthotists to create the best outcomes for kids and adults who have scoliosis. So it's not a fix-all, but instead using it together with bracing and education to make sure that someone has the best possible outcome and to stop the progression of scoliosis. So, and it's important for physical therapists who are trained in the Schroth method to identify that and then work together with pediatricians, orthopedic surgeons and doctors, and the orthotists to make sure that someone has the best outcome. Okay, I think I kind of went over that a little bit. Additionally, PSSE should be done by a PT that is especially trained in a school of PSSE, which I went over, and works as part of an interdisciplinary team. Generally, we say it's not an entry-level skill for PTs based on the advanced curriculum and understanding that you should have of the human body, anatomy, and physiology. There's a common language that orthopedists and pediatricians and PTs speak, and so it's good to understand and kind of have that working language that you can share amongst yourself and with your patients. And unfortunately, not all communities have this full team of scoliosis professionals, but at UCSF, we are building the Spine Center of Excellence every day and working together with any pediatricians or local therapists who want to reach out and make a connection with us and make sure that all of these adolescents get the care that they need. Let's see. PSSE is a plan that's patient-centered and goal-oriented, based on each individual case according to, and when we say specific protocol, we're talking specifically about the corrections and identifying what curve type they have. We need to have a strong understanding of risk progression for immature patients. You should understand additional variables related to scoliosis that influence each patient's plan of care. And you should be able to evaluate the quality of life, as I was talking about before, because I think that's at the baseline human level, making a difference in especially kids' lives as they're growing and changing in their spine. Okay, now what you guys really want to see. What the heck do I do? All right, so I'm going to show you a few of the really basic exercises. And so one of the big things that I do as a Schroth therapist is make it doable. Because a lot of times, most kids are wearing a brace for anywhere between 16 to 22 hours a day, or they're sleeping in a brace at night. So when I tell them, oh, hey, you need to do 45 minutes to an hour of these corrective exercises, I know it's not gonna happen, right? Most of us have kids or we have busy lives. So my goal is to give these kids something that's easy to do, but they can also take ownership of it, right? They can see the difference. They can look in the mirror and say, you know what, I noticed, Miss Jamie, you said my pelvis is going this way, and I'm gonna work on trying to bring it to center and then really take ownership of their body and their curve. And so that's the goal of these basic exercises. First, we call this semi-hanging, where she's working on elongating her spine, getting that nice long axial elongation. The second one, that's supine, where we add some correctives at her convexities and work on breathing into the concavities. We have side lying. So for this specific patient, oh, excellent. I thought I had a laser. Okay, her convexity is here. Her concavity is on the top, and then her convexity of the thoracic spine is there, and then she's just blocked at the shoulder. And you can see we're really working on trying to open up that side. Here we're working on just nice long positioning. From the front view or the head view, you would see we blocked the shoulder. So I think it's important to share a little bit of changes that I've seen in some of my patients. And so I'm going to share a case study with you of an active female dancer who really, really bought into the program, primarily because she came to me with fear about having to have surgery. And when she came to me, the goal was really to help with pain management and for her to just try to prolong her surgery as long as possible, because she was a really active dancer and she was a senior at the time and she just wasn't ready to have surgery. So that was our goal, is just, get your posture better, let's work on your pain, let's work on your spinal alignment, and then we'll revisit in 6 months and see how you look. So I'll go through the case study and I'll tell you what happened. She had right-sided low back pain. It was really low. Mostly they think it was related to her Bertolotti's at L5 on the right side. She was diagnosed with scoliosis at age 15, and she wore a Boston brace for about a year and a half. I actually saw her after she stopped bracing. Her mom sought me out. And she said, I've heard about this Schroth thing. Let's just try it. My first appointment with her was in June of 2023. And she had one session privately before that as kind of an intro. Her surgery was planned for late 2023. Here's a X-ray that came to me from her doctor. Specifically just kind of looking, number one, at her central sacral line. You can see here, maybe. Oh, that's because I'm clicking the wrong button. Okay. Specifically, we line up the center of the pelvis with T1, and you can see she's pretty shifted to the left, right? She has a primary lumbar curve, a secondary thoracic curve, and she's pretty shifted to the left. Therapists who are trained in PSSE are also trained to read and understand x-rays as well, just so that we know and we can follow our patients. We can look and just kind of follow along and say, okay, is this patient making the correct changes we're looking for? What is their Cobb angle? Just make sure we are like comparing what we're doing as well to what the ortho is doing. Her thoracic Cobb angle was 34, her lumbar Cobb angle was 43. So here's some pre-treatment photos. We always look at our patients front, back, right, left, and we kind of look at their alignment, right? So we center the feet and we go through the belly button, and you can see we have a pretty significant left shift. Her nose is way to the left. You can also see in the posterior view, we have a really big right pelvis shift and moderate lumbar lordosis. So we're gonna work on all of those things. In semi-hanging, working on trying to level out the pelvis and kind of adjust and make sure that her pelvis is level. She's still shifted to the right. We're working on it. We're trying to make those changes in the correction and the connection between the brain and the spine. We did about 4 specific positions and some strengthening, because she's a senior. She's very, very smart. She was very committed, but she was also an avid dancer. So I didn't ask her to do 3 hours of Schroth every day. I asked her to do 20 minutes, 25 minutes max. So she would pick a position. She would work on her breathing exercises, trying to maintain her alignment. A few of these we've seen before, but really working on getting that nice 3-dimensional correction using the belt to stabilize the pelvis, the correctives to bring her spine to neutral as best as we possibly can. And then you can see she's working on trying to open up her concavities and maintain that nice long spinal alignment. This is an overview of the program that I did with her. I saw her for about 16 treatments. Here we have about 45 minutes with our patients. And that was over 12 months. I actually still am seeing this patient randomly when she comes back, and we just do some check-ins. We did our 5 main positions: semi-hang, supine, side lying, prone on knees, and prone on stool. And she could choose to do as much or little as she wanted, but she was very dedicated. We did some soft tissue massage. We did some cupping to try to help manage her low back pain. And we worked on standing and seated postures, that integration part of it. So I didn't just have her laying down on her back and breathing. We actually stood up and tried to integrate that into like a gravity position. And then I had her just do a symmetrical strengthening program. You can do some strengthening extra on the like primary thoracic side, but generally with the Rigo method, we encourage symmetry. And I didn't integrate that right away. I did the scoliosis exercises initially and then added strengthening when she was ready. So here's a little view of her x-ray in May, right before I met her, and then in September. We had some pretty good corrections. I'll also add that after this September visit, the doctor did put her in a night brace. She had a Providence night brace that she wore for about 8 to 10 hours. But with just some corrective exercises, diligently, she had great outcomes. 43 degrees down to 36. Thoracic improved 34 down to 28. Her upper cervical thoracic didn't change a whole lot, but the doctor's main concern was her 43-degree curve, and that's where she was going to have surgery. So it was nice to see a nice improvement there. And here's some pre and post from November to February. I think the nice thing is she was really happy, but you can also see we're really left shifted. And then after that time frame, she's really a lot more stacked. And I'll be honest, I didn't tell her what to do. I don't tell any of my patients, go get your x-ray and do your 3D corrections. If they want to, they can. But I'm hoping that they're integrating this in. I just say, go stand over there on the line and let me take your picture. And then I show them what they have done, right? That's them taking ownership of their spine and that nice correction that they can get when they learn how to level out the pelvis and stack their blocks and really open up their rib cage and stand tall. They're able to do a self-correction. How long they can maintain it is based on their endurance. But this girl was just shocked. She was like, I can't believe that I can actually do this on my own. And she had some really nice corrections. You can see, there we go. We have this nice center alignment. Not perfect, but so much better. And even we've reduced that lumbar lordosis, and her ear, shoulder, and greater trochanter are really nicely aligned. We try to take a lot of measures at the initial eval and compare. But one thing I think is really important to note is that we had a really big improvement in her breathing. Normally she was breathing really high up into her upper chest, and we actually reduced that a lot. And then we had a nice improvement in our diaphragmatic breathing. Right? Those things can apply to a normal life, test taking, stressful situations. She's learning how to breathe into her diaphragm and expand and stand tall. Here's her x-ray at the end in August. So a nice improvement there. And some more pre and post treatment photos. So that's about a year later. I think really the goal of the Schroth method is to work on 3-dimensional pelvic corrections, stack the blocks, engage the postural muscles, lengthen the spine, and encourage kids to try to do this every day and integrate it into their lives, to give them the confidence that even though they didn't choose scoliosis, they can choose that nice corrected posture, and then they can see the difference. Now, for this girl in particular, she actually ended up not having surgery. The doctor was very happy with her changes. She may need surgery in the future, but her growth plates are closed. And so, as long as she continues down the path of continuing the corrective exercises, hopefully she can stay without getting a spinal fusion. But once again, that was not our goal to stop her from having a fusion. It was just an outcome, a really great outcome from adhering to the postural corrections, these really nice, easy postural corrections. Okay, I have a few minutes for questions. I just kind of, I've taken 2 courses, and hopefully in the next couple years, another one to just keep my education going. We have a couple minutes, so if anybody has questions, thoughts.
They continue with the exercises throughout life? Is that kind of...
So when they're in PT with me, I have them do their exercises every day. 15 minutes, try to do it every day. As they move forward, yes, I would like them to integrate the postures throughout their life. Whether or not they remember it forever, but they will come back and try it again, we'll reset. But the goal is that you learn that postural correction and you carry it throughout your life, because you have scoliosis for the rest of your life. So, as we age, and our bones change, if you know that correction, hopefully it can give you some relief as you go throughout your life. Yeah, thank you. Do you want anybody to use the, he has the mic.
Hi, I've been told that you can't use this method with neuromuscular scoliosis. Have you treated anybody with that, or do you have any comments about that?
So I have a few thoughts. One is that yes, you can use it, but I found it to be a bit more difficult to maintain the corrections because of the tone that kiddos, for example, with CP have. It's a bit more challenging, but I think it's worth trying to see what corrections you can make. But you're really going to be battling whatever underlying neuromuscular disease they have or change. I've had kids with CP go through it, but I will say our outcomes are not as good as for this. For example, this girl, it's a bit more challenging. But I don't think specifically, if I were to ask Dr. Rigo, the creator of this method, can you use this with kids with neuromuscular diagnoses? I think his answer would be yes. Does that help?
Yeah, just it seems like it would be helpful even if you're not preventing surgery, but
Yeah.
I've been told so many times that it's not for, neuromuscular scoliosis, that I haven't, tried to look into the training for myself.
So is it okay if I bring up your question?
Yeah.
Another therapist asked me a little bit about this training, and I was trained in the past couple years in San Jose. Dr. Rigo has therapists in the United States who lead trainings, and there's at least 2 trainings a year in San Jose. So if you guys want more information on the Rigo method, I can speak to that one a lot, but there are quite a few trainings in the United States available to therapists. Rigo does not train chiropractors or physical therapy assistants, but other methods do. So I can give you that information offline if you want it.
Sure, thank you.
How well have you seen this method work on people who have had surgery but still have remaining curvatures because they didn't fuse everything, right? Mm-hmm. And then also, what about the method for more of a kyphoscoliotic patient? Because that patient was not that kyphoscoliotic. So.
Okay, so your first question. Generally, when you're level 1 or level 2 trained, they don't teach you how to correct someone who has a fusion, primarily because it's an advanced technique. Now, with that being said, I have been treating kids who have had a fusion of maybe, say, their thoracic spine, and they still have a lumbar curve, still have a significant pelvic shift. We cut out any traction. We don't do any hanging. We don't want to pull on the fusion. And then we just work on trying to integrate the pelvic corrections. And you can add a corrective to the part of the curve that is not affected by the fusion, but it's very, very gentle, and it's really focused on strengthening. Because most of the time, they're post-surgical, so you have a lot of strength and motion deficits, whether it's even hamstring limitations. So I don't have a case study on anyone yet who we've done Schroth after a fusion, but I'm hoping for good outcomes with them, because you can still work on the part that's not fused. Your second question about
but what about a fusion that happened 5 years ago?
I think you could still integrate the principles. You can still do your pelvic corrections, your elongation. You just wouldn't do any hanging or traction.
You still wouldn't do that.
Mm-hmm.
Okay.
Yeah, even if it's a really long time ago, the last thing you want to do is pull on any part of the fusion at that point. Yes, you can use this for kyphosis or an inversion. Those are type 1 or group 1 type of scoliosis, and you would just modify your position and where you place the pads. But you would still integrate the same pelvic corrections and teach the axial elongation as well. You just apply it slightly differently. Yeah. Great questions. And there we go. 4:20 on the dot, Tom. Thank you, everybody.